early institution of the right management essentially impacts favorably in the outcomes. Ria was a 14-month-old girl and started exhibiting mild developmental delay, some clinical regression of signs. And at the first seizure at 12 months, this was kind of the phenomenology of the seizure, the semiology, as you would call it. And then I have paraphrased through the rolls and rolls of notes around Ria's story as to what kind of seizures she was having for the benefit of the multidisciplinary audience that we have today. She was tried on several anti-seizure medications, ketogenic diet, within a short span of that time, because people were really trying to control that seizure. We know that the earlier you control the seizures, the lesser the axonal degeneration in the brain, the lesser the impact on development, which was mild to start with. So some excerpts from her scans. She had an initial basic MR scan. It's the story of many people's lives. Every child does not get a straightforward, sophisticated, beautiful appearing scan. This is the real world data that we have to deal with. And I have just put to you there 2 slices on some bread and butter sequences, T2 and T1, which is still the mainstay of imaging modalities in terms of trying to detect those lesions or even trying to decipher what might be going wrong and then trying to narrow down the areas that might be relevant for surgical resection, if at all. Or you might pick up multiple lesions in multiple locations, which could then render it a genetic form of epilepsy. And whilst you're pondering whether the left side is abnormal or the right side, and if you're wearing the radiologist's hat, you're trying to pick up, is there atrophy on one side or is there overgrowth on the other? Let's go back to the story, but the seizures were kind of mixed patterns and not controlled and quite refractory. So there's something on some side which is relevant, but the scan at that point in time was read as no obvious localizing or lateralizing features, a report that you will often encounter in practice. The next step that followed in Ria's care was a video EEG, just going through the fabric of her life. At the ictal semiology, she had all these various activities going on. And I will let you peruse the slide because the clinicians in the audience will be very interested to know what was the seizure type, where was it coming from. For a radiologist in the audience, when you give us all this information, we basically get a bit lost. We have to go back and keep asking you which side of the brain is the seizure coming from, which is the affected side, because things can be ipsilateral and contralaterally made out quite difficultly, and then the side goes wrong in terms of lateralization on the imaging. So here is the interictal asleep, where you see some slow wave forms. I'm not an epileptologist, but I'll try my best here. And slower right more than left kind of activity. So something from the right side for sure. Then we look at a few more of these runs still on the interictal side. This time we're looking at the F4, and there was some upper frontal spiking, which was seemingly extending to the midline. I guess you all are agreeing with my description of these waveforms at this point in time. And then she had an ictal onset awake, eyelid twitching kind of captured in that run, and things go a little bit all over the place. But these were the pickups in terms of where the localization was possibly coming from. And once that information becomes available, I do definitely go back to my neurophysiologist and ask them, what is the summary of all that? Just give me in simple English, where am I looking? And they said the semiology and the ictal interictal EEG was consistent in Ria's case with a right frontocentral neocortical onset. So they're saying right, and I was thinking maybe the left side was atrophic. So there is a discordance, which is typical in the real world practice that we are in. A repeat MRI was done, and I'm not showing that here. It was an epilepsy protocol scan, was still reported negative. There was no obvious cortical dysplasia with a tail. The changes on the left side, which were initially perceived as atrophy, were stable, and it was a so-called lesion negative scan. And once you've had your epilepsy protocol MRI, now that is quite a variable practice across the world, and you've had your video EEG, you have basically, as per the ILAE recommendations, completed the tier 1 of investigations. So at the end of tier 1, Ria did not really have a concordant answer or a structural substrate, but there are cases where they remain lesion negative. But I think in 2023 AD, when we practice, I think we have to be really careful about calling something a lesion negative scan without thinking about the ictal onset zone, the irritative zone, and all the other zones kind of scattered around what that lesion might be. So this is when tier 2 investigations are commenced, and that was a PET scan. Now, I'm aware of only one center in this world at the moment, correct me if I'm wrong, which is Melbourne, where a PET and MR, an epilepsy protocol 3 Tesla quality MR, and a PET is done as first line investigation, which I think might be a good way forward if you have the resources to sustain that. Which in this particular case does show changes in the metabolism or the functional activity of the brain, particularly from where the semiology was showing on the video EEG. There are other questionable areas. This is the problem with PET. There might be other areas, and then you have to go back to the MRI and start matching. And we're still not really sure as to what we are mapping there. But we can have instances where the PET is positive and the MR is negative. We have encountered that quite commonly in all our practices. So we thought we are now going to deal with something that will need, as the next step, some kind of invasive monitoring. So questionable arrow placed where the PET was, and it goes to a discussion for invasive monitoring. Now, if we go back on a bit of a time hop, we know that at the moment, the mainstay is stereo EEG across many epilepsy centers in the world. But subdural grid electrodes were used quite commonly in the past, and certainly in Ria's time when this case emerged out of our archives, there was a big discussion about whether we should still have subdural grids or an SEEG, which is the current standard of care. And I thought I should bring that back to discussion because, resources and allocation of resources are quite variable across the world. And once again, looking at these basic advantages and disadvantages of the two techniques, as in this particular case, it was decided to go with a stereo EEG, which we had then at that point in time in our center. And though it was an expensive toolkit compared to the pretty traumatic subdural grid electrodes with pretty poor pickup rates, it was decided to go for that particular modality. So implants were put various places. This is more for radiologists to see what these look like in real life. At the moment, we have a joint meeting with our SEEG team, and the MRI radiologist is there to basically provide the concordance to where all the implants should go. Additional implants are made of electrodes into areas which the radiologist thinks should be interrogated as well, or the neurophysiologist thinks should be interrogated as well. So there is a bit of improvisation. It's a bit like jazz, that particular meeting, where people decide to make it precise for the patient rather than follow just one standard of care. In this particular instance, there was an initial pickup of the supplementary motor area, but there was quite a prolonged kind of area that was visible from the superior frontal sulcus, almost going into the SMA, going into the cingulum as well. So that's where the lighting up happened. And we are able to kind of co-register the two modalities and try to provide some surface anatomical correlations as to where the electrical activity might be coming from. And the depth electrodes localize the ictal onset to the SMA, cingulate gyrus, the superior frontal gyrus. In this particular case, the patient went on to have, at 15 months, a resection. And at the point of that resection, she was able to give us an answer to her problem, which was a histological focal cortical dysplasia type 2. Now, the types of focal cortical dysplasias, I think, are in constant evolution. I'm waiting for the next iteration of the pathologists to kind of revisit what these types might mean. At the moment, to a radiologist, we are looking for a tail of signal change extending to the ventricles. We don't always see it, but I don't think we need to be tempted to go around subtyping focal cortical dysplasias as long as we can pick that up. But this was eventually only really picked up on histology. And really going back to the scan, you wonder whether there was something there or not. And I wonder if we should have ever labeled that as a lesion negative scan to start with. But that aside, it's not about whether the radiologist or the neurologist or the epileptologist got it right or wrong or delayed or procrastinated. It is about the final beneficiary, and that was Ria in this case, operated at 15 months. Histopathology confirmed a focal cortical dysplasia, remains seizure-free, making developmental progress. And that last bit is extremely important. This is something that I learned from Dr. Gill in Sydney, and this is what he teaches, a beautiful picture that he uses there in terms of how the propagation of the activity happens across the brain. It's not just always in the epileptogenic lesion. There is a process of axonal degeneration that might be happening across different networks and new areas getting recruited in that process. You might end up getting a very generalized seizure kind of syndrome, even in the context of focal lesions. And the outcome developmentally is quite poor. So developmental and epileptic encephalopathy emerged as a concept abbreviated to the DEE because the epileptic activity in itself would be severely contributing to those cognitive declines very early in life. So it's important, therefore, to address that issue early, operate if need be, or whatever tampering has to be done, whatever intervention has to be done, whether it's going to be photocoagulation, laser, surgical resection, or even escalation of therapy, then I think the idea is to prevent other comorbidities in the future. Some of us are in mixed practices. It's not just about pediatric epilepsy. It's useful to have a glimpse of the substrate of epilepsy across children and adults, and also to compare what's common in what kind of spectrum. There is a big focus on cortical development, particularly focal cortical dysplasias in children. On the contrary, in adults, it's more about mesial temporal sclerosis, vascular lesions, and then we have the tumors and the clastic processes of the brain. And this data is kind of historic at the moment, but from a large surgical series in terms of matching children to adults. And it does show a statistically significant difference, but also some common ground across all ages. So if you're in a mixed practice, it doesn't mean that you are not doing well in terms of pediatric care. I think you're probably adding more value because the skills are quite transferable. The key challenges in children is the fact that 50%, up to 50% of children with epileptic encephalopathy do have a structural abnormality. And the more scary fact here is that up to 70% of lesion negative children, when we say scan is lesion negative, we do harbor a focal cortical dysplasia. And that is to be picked up and dealt with. And finally, the spectrum of infantile spasms, because they're the ones that present quite early, apart from the Rasmussen spectrum, unless children have a tumor or tuberous sclerosis. The infantile spasms are the ones where it's very hard to pick up focal cortical dysplasia because the myelin is still very immature. And if your sequences are not optimized to gain contrast between the T1, between the white matter and the gray matter, you will be missing out. And I think we probably all have missed lesions on these infantile spasm cases, but 25% of them harbor focal cortical dysplasias. And then finally, the challenge is to look for bilateral abnormalities. Sometimes things look very unilateral, very much on one side. Here is a clastic process with a presumed perinatal arterial ischemic stroke involving the middle cerebral artery on the left side. But if you look at the contralateral, you will find a little bit of periventricular scarring always on the contralateral side as well. What does it mean to the outcome of the patient? It is being addressed by some researchers. There's a bit of a mixed literature about it. Overall, people would assume that the outcome from a functional hemispherotomy in this case would still be quite good, even if there's minimal changes on the other side. And then you have a situation of an mTauropathy here leading to a hemimegalencephaly. Even in the hemimegalencephalies, when you look carefully at the contralateral side, you come across areas which are dysgeric or badly formed. You don't know how to call them. They don't look like frank polymicrogyria. And these patients go with the tag of left-sided hemimegalencephaly. And then when you operate them, they might be seizure-free at 1 year, and then in 3 to 4 years, the seizures may recur. So it's always good to go back to the imaging to see whether there was anything on the contralateral side that should have been dealt with. It still might mean the patient goes on to have a functional hemispherotomy because it's a risk-benefit analysis, but I think the savvy radiologist should definitely question the so-called normal contralateral side. Now, here's an interesting entity, the Sturge-Weber syndrome, one of the biggest misnomers in epilepsy. This is not a PL angioma. An angioma means a tumor by its name. This is a bit of a venocapillary malformation on the surface of the brain. You can see why it would be called that, but it has been labeled as a PL angiomatosis. And unless you really look carefully for bilateral changes, you will miss them. And that is why we advocate even not just doing a T1 with contrast, doing a flare with contrast, giving contrast, even if the child has just been born with port wine stains and a lot of seizures. The Americans don't completely believe in giving contrast to young babies looking for Sturge-Weber syndrome, but it is the test of choice. If you're doing a scan, give the contrast. If you're giving the contrast, do the T1 and the flare after contrast, and you will pick up bilateral changes, which may not be obvious on your T1 or otherwise, even on your susceptibility weighted imaging, etc. And then you encounter situations like this where you have a unilateral lesion. It's probably difficult to see on Zoom-based platforms, but a bottom sulcus dysplasia. But this kid might be having seizures from various other parts. Is it a one lesion or is it a more extensive lesion? You can see that there is a difference in the folding of the temporal lobes extensively on both sides. And then you start questioning the validity of what is unilateral. Step two in that process is challenging the lesion negative scan. Now, it's easy when you know there is a hole and the child is seizure free. We like telling our success stories. We have got things wrong as well, which look like focal cortical dysplasias were removed and the histology is negative or non-specific. Child may be seizure free. So there's a lot of the gray area in this practice, but it's always interesting to go back and look at what was initially called as lesion negative, clearly wasn't lesion negative at that point in time. Across the world, different pediatric centers are trying to make epilepsy imaging more and more sophisticated, for want of a better word, and trying to throw a lot at it, particularly in the quest of the focal cortical dysplasia. But I quite like the harness MRI protocol. My only misgiving about the ILA publication around the harmonized protocol was they did not have a radiologist providing consensus to this protocol. But in spite of that, they did quite well in suggesting to the world that even if you have to do something basic, get a high resolution 3D T1, a high resolution 3D flare. And by the time this was being published, this was becoming the standard of care. Any system could give you a 3D or a volume flare of some description. And then a coronal in-plane resolution, more for the hippocampal assessment or the mesial temporal assessment. Now, we don't always need to do that. If you have a good quality 3D T1, good quality 3D flare, you still would do an axial T2. You could throw in a coronal T2 as well if you want, and then you have the benefit of diffusion as well. So that's your basic sequence set. Beyond that, and I will show you what all is happening in terms of trying to improve the gain from imaging, there must be some value added because the practice is quite interesting. I'll share that with you in a moment. But what we are trying to look out for are these three basic subtypes of histological dysmorphisms. You have an architectural dysplasia, or you have an architectural and cytological dysplasia, or you have an architectural dysplasia with a second pathology is what we are gunning for. And the second pathology could be a tumor. And you can see why we talk about this as an ILAE3 kind of lesion, which could be a tumor, which could be a vascular lesion or something else. So what else is happening in the world of let's look for focal cortical dysplasia? If you have a good quality 3D flare and you have a good radiologist with good pair of eyes, you should be able to get pretty sound output in that respect. But systems and physicists are enabling a lot more contrast gain to happen. So this would be a Siemens system. Most of these funny names are sequences. This is still a volume T1, but this is a gradient echo, for instance, done twice and two different inversions, and you add the additive effect of those two creates a contrast where you have kind of improved the conspicuity of that lesion. This is the T1, this is the flare. Beyond that, you are able to saturate out not just the fluid, you can also saturate the white matter signal. These are simple physicist tweaks of sequences, and you can see that the conspicuity of that lesion can improve. This is called flaws, it is fluid and white matter saturated. And then finally, when we do the MP2 rage, we can do this computational edge enhancement, as it's called, and the edge enhancement itself can give you a good conspicuity of the lesion. But the reality of practice is that if you have picked it up on your 3D flare, everything else becomes additional. So far, we've done this for 6-7 months, and we have been doing the edge enhancement, the MP2 rage. And I must tell you that the yield, I think, is pretty similar to doing the standard T1 and the flare. But what it helps you with, it does give you a different perspective. It gives you a different contrast. And using that contrast, you can actually do a few more things. And this is what we are doing at the moment with our research colleagues, Conrad and Sophie. They are also husband and wife, but they initiated the MELD network, the Multi-Center Epilepsy Lesion Detection Project, as it's called. And it's an international call out. Some of you might be aware of the MELD, particularly in Europe and certain parts of the States as well, where data is being gathered and the whole focus is on focal cortical dysplasia and its characterization using AI and machine learning. So going beyond the gray-white contrast into cortical thickness, sulcal depths, intrinsic curvature, and then looking at various other kind of things that AI can give you, and then trying to predict where there is an alteration or a change from norm, and that's highlighted with a bit of a color or a light, so to say, and then the radiologist goes back to that area, the epileptologist goes back and focuses on that area to see if there's concordance. It is a lot of work that has already been done, some really cool publications that have come out of this network. And I think if we have to do AI well and use automated systems going forwards, it's not just about lesion detection on imaging, but also to look at how deep learning can be developing algorithms for automated segmentation and histopathological classification of focal epilepsies. And that would be true radiogenomics in its own way. So if you are interested in your center being a participant, the idea is to collate as many as possible of scans and put them through the system. The system improves. You can see there's a bit of a world map there. Not seeing much of Canada, but if you're interested in joining, Conrad and Sophie will be very keen to hear from you. And that's their simple email if you want to take a screenshot and get in touch with them. And they can set up things for you. They are based at the University College London and the Great Ormond Street Hospital at this point in time, but the network is very international. Moving out from AI to real world again, this is step 3, improving the detection of focal cortical dysplasia. And this is where I learned a lot from my colleagues who I work with, and we look at scans together. And this is what I'm talking about as spin academics. There's Nihal in the meeting, there's Pradeep in the meeting at the moment, and they will recognize some of these slides as well that we have been using in our collective teaching pool. First thing is brain maturation. Now, sometimes it's easier to pick up the contrast of the culprit lesion when the brain is still very immature. And that is to do with the relative water and lipid content on the T1 and T2 weighted sequences. So on a neonatal MR, malformation of cortical development will appear quite dark, as you can see, and that contrast naturally happens. And as kids mature, corollary can happen as well. So there is a time window where it becomes tricky again to see these lesions. And then things start becoming a bit more obvious when they get older. What this shows, the neonate, the 6 months, the 22 months, shows is that there is a dynamicity, and the dynamicity is to do with the imaging metrics rather than the lesion itself changing. But the lesion in itself may be evolving at an ultra-textural level. And when we start looking at tuberous sclerosis in a few slides from now, we will be revisiting that concept a little bit. So there might be a little more that MRI can offer us using texture analysis and radiomics, going back to machine learning techniques, to detect the mapping of the lesion area a little more eloquently. But here, you would really struggle to call anything at 6 months, but things become a little more obvious when you start looking at 22 months. And in fact, you also start wondering about the contralateral side. When you have multifocality, you should think about genetic epilepsy syndromes anyways. Now, the reason to show the slide is not just to show you how happily we can pick up lesions on 3T and 1.5T is bad. I think my message to you is that a well-optimized 1.5T system is better than a poorly optimized 3T system. And we all practice across scanners in different hospitals, which have either a 1.5 Tesla or a 3 Tesla. And there are still countries in the world which have a 0.75 or a 1. And then we have a technology that is coming up, which is called image quality transfer, where you can upscale the quality of that. But even if you don't have that, if you have a basic 1.5T, you can still detect that lesion. It's not that it's not visible. And you just need to optimize your sequence well. And I can tell you that that flare there could be optimized a little more. Something else I've learned from my colleagues here is also the fact, and it's true as well, what we get as output to look at the scans is the reformatted version of our scans, but it's important to go back to the native resolution of 1 millimeter isotropics, where your lesions become quite significantly clearer compared to what you would get when you have a slightly bigger slice thickness. You're losing some information in that respect. Important to go back to your basic flare sequence and literally partition the windows, as we call it. You take your mouse and you scroll across laterally and things become darker elsewhere, and the gray-white differences which are altered come out quite nicely. It's the same picture which has been grayed out just by the act of a mouse. Check all planes. We have always encountered these situations where we see something or not see something on the axial becomes vivid on the sagittal or the coronal planes. You might struggle to see this on the coronal, becomes quite clear on the sagittal. It's to do with the mapping of the dysplasia in itself, and it's important therefore to have multiplanar imaging. The bottom of sulcus dysplasia is interesting in itself. First of all, it's important to know where the semiology is. And this is kind of where what starts mattering is using the MP2 RAGE or the edge enhancement. This is kind of where we are trying to find those little lesions which have not been picked up or have been missed initially on initial reads of these scans. Diffusion is very useful in children, and particularly in the context of ADC, where you have nodules and the nodules show some reduced diffusion values, can appear quite bright on the DWI. And in the very young children, that becomes quite interesting because you might not see it on the other sequences easily, but you'll pick it up on the diffusion. Tumors, they can coexist with focal cortical dysplasias, as in this particular case. What you have is not just a small temporal lobe on one side showing corroborative PET changes. There is blurring of the gray-white interfaces, but when you give contrast, there's a heterogeneity to it. And the ILA3 lesions, which are usually a glioneuronal tumor, which is epileptogenic in itself, can have a mixture of focal cortical dysplasia and tumors in the same vein. So it's a bit of a spectrum, or the two ends of it, if you think about it. Then on from there, important to remember that corticogenesis follows vasculogenesis and vasculogenesis follows corticogenesis. So if you have abnormal vessels, say a developmental venous anomaly, then do take it seriously. We generally call them benign entities or an incidental finding, but sometimes, and I think when I say sometimes, maybe in up to 15 or 20% of cases of epilepsy, when you have a DVA, when you look carefully around it, you will pick up a neuronal migrational failure or some kind of a cortical malformation, as in this particular case. And this is a good example of corticogenesis and vasculogenesis following each other. What has emerged more recently is this context of a mild malformation of cortical development with oligodendroglial hyperplasia. Not many of us have examples of this. The histologists are still scratching their heads on whether this is a real entity or not. but it does histologically what is picked up as an oligodendroglial hyperplasia. Radiologically, you typically see the subcortical lines or bands, as you can see out here. This was the initial publication by Urbach, still quite a nice picture. And this child went on to have resection of the frontal lobe out there with complete surgical, complete epilepsy control after that. Difficult to see on the T1 weighted sequences, as you can see. Finally, do not stop at one. If you have picked up one lesion, it is important to look around what's happening. So here the hippocampus is small, but the parahippocampal as well as the fusiform gyrus is involved. And I think if you do have a way to do volumetries, you would probably pick up a volume of the temporal lobe smaller compared to the right as well. And the human eye doesn't always pick these findings up. When you look at the waveforms, they are a bit all over the place and not all that specific. This child had focal seizures to start with and then became more generalized. So it's important to tell the surgeons that it's not just the hippocampus they need to take out. And in children, finding isolated hippocampal sclerosis is actually unusual. They often have a previous encephalitic episode with scarring elsewhere, or there might be adjacent changes, and the hippocampal sclerosis in itself could be secondary. Look for the nooks and corners, some more tips and tricks coming your way, apart from looking at the volume of the temporal pole anteriorly out there. In this case, we are looking at the basal region frontally. On the same vein, when you have a case like this, for instance, this is interesting. We had to do a CT scan. I'll tell you why in a moment. But when you scroll slowly, you will come across small little encephaloceles there. And it's hard to show it on a Zoom platform, but there was a bit of brain tissue plunging through a defect. The surgeons wanted to know what the defect in the skull base looked like. Hence, we did a CT for them because they wanted to get their coordinates right. If you fix that, if you push that back up literally and seal this, you can gain seizure control. And some initial papers on this, which were quite telling. And once in a while, we have all encountered these encephaloceles, which have been causing the seizures. And such a cool spot on imaging. Importantly, you can gain complete seizure freedom if you're able to identify that. And I've been informed that the semiology is quite typical for these anterior temporal encephaloceles as well. Once you have the PET, and this is really the final clue in terms of trying to get it right, go back to the MRI scan and you will start at least neuro-imagining things first to start with, and then trying to build a case from there, whether that sulcus is quite thick at its basis with some blurring of the interfaces of the gray-white matter or not, but it is fairly concordant and fairly focal as a lesion, which may not be seen easily, but then you start looking at things and you even find the tail and you know you've picked up a focal cortical dysplasia type 2. Talking about focal cortical dysplasias in multiple locations, we have to remember tuberous sclerosis, yet another mTORopathy. And in the context of mTORopathy, these kids generally have big heads. And this is an overgrowth phenomenon. These are large balloon-like cortical dysplasias in multiple locations. The problem is which ones to remove and which ones not to remove. And children present with pretty bad seizures early in life. And we are often asked the question, which do you think is a dominant lesion in this particular case? Now, traditionally, and this is without any evidence too, the fact that we think that the larger tubers or the calcified tubers are probably the dominant tubers. We still use that in practice, but I don't know how much truth is there in that statement. The other problem with TS is once you've done a focal lesionectomy, if you've chipped away at one or two, the others start becoming active because there seems to be some networking that's already going on in these brains. And the longer you leave them untackled, the longer and more intense those networks become. So in the context of tuberous sclerosis, and this is something which I'm just looking at this point in time, based on the 2019 publication, people started looking at which tuber types are epileptogenic and how do you define the dominant tuber. And Neil and his team were able to pick up certain features like ill-defined or hyper intense or heterogeneity within the substrate, looking at the tuber rim, the tuber center peg. And when I looked at this picture, this was 2019, the uptake of this in practice is quite poor because it's very difficult to start mapping each of these tubers out. And this is a bit of a research leak, really. What we're looking at now is radiomics or texture-based features of these tubers in itself. But it's a lot of work in the background because we have to literally draw around each tuber to see what their radiomics features were and then match it back to the electrics as well as the outcomes if they have been resected. So that's a bit of work to follow, and hopefully we will be able to tell you more when we are able to publish that. Step 4 is speaking the same language. Now, this is important because the substrate is generally a malformation, and the substrate could be quite generalized. So in our humble efforts through the pandemic of trying to generalize things and provide definitions for standardization, this is a piece of work we did with the NeuroMake cost group. And we said, let's look back at the malformations, get the descriptors, and essentially we would request everyone out there to start speaking the same language, translated into whatever language you want to report in. But lissencephaly, for instance, thickened cortex, abnormal gyration ranging from agyria to oligogyria. And this I'll kind of go through very quickly just to show you the spectrum of cortical malformations and how their definitions have evolved for consensus. Then we have the context of simplified gyral pattern, where we have a reduced numbers of gyri with very shallow sulcal pattern, if you look at the surface out here, and normal cortical thickness. Now, we don't really advocate measuring cortical thickness as such, but if this case was put through an automated system, it would give you that readout on its own. Cortical thickness is normal in simplified gyral pattern, and that factor is important when you start looking at entities like dysgyria, where again you have normal cortical thickness, but an abnormal gyral pattern characterized by abnormalities of sulcal depth and orientation. You can see how these sulci are almost vertical and horizontal to each other, separated by abnormally deep or shallow sulci. And quite disordered in its own way, in the way it's arranged. Dysgyria is a relatively new term. It seems like a bucket term at the moment. It was initially used for tubulinopathies, but there are quite an increasing number of entities where we can use this term. They're not the bund or lissencephalies, they're not the bund or heterotopias, or even the polymicrogyrias. Then we have the migrational problems, the subcortical band heterotopia. And here, remember, the thickness of the cortex is all the way from this margin out across. So even if you say that this is just a band, the cortex is abnormal because those neurons have failed to migrate out there. Of course, these are not really surgical candidates in the strictest sense of the word, but they may need some palliative surgical techniques. We'll look at that in a moment. Further on from the subcortical band heterotopia emerged the configuration of the ribbon heterotopia. Once again, you can see that it's quite a thickened cortex all the way out, and the outer and the inner bands are abnormal in this case. On first look, you might think that this looks like polymicrogyria, but this is a total failure of migration, and the so-called sparse zone in the middle is quite widened out here anyways. Then our quintessential polymicrogyria, important to see it in multiple planes. The sagittal is the most useful plane, I would say, but you can pick it up on different planes and then further characterize it. So if you just focus your attention on the posterior aspect of this groove here, around the sylvian fissure, or you can look at this area here in the frontal lobe as well, you will pick up multiple small gyri, which are packed like an accordion, the instrument. And of course, polymicrogyria is quite diverse in its presentations. It could be just a cortical phenomenon. It could present with small polymicrogyria or large areas of involvement, or with associated white matter changes, depending on the driver of the polymicrogyria as well. And both asymmetric and symmetric patterns are well known. Now, this is a bit of a change that we have hopefully advocated in the 2020 paper on consensus statements, the cobblestone malformation. Now, the cobblestone and the polymicrogyria mimic each other quite strongly. Typically, the cobblestones have this white matter signal in the subcortical zone, and we know that the inner area is a bit kind of smoothened out. In polymicrogyria, it's more lumpy and bumpy and all that. But essentially, there are instances where you'd struggle to call something cobblestone or polymicrogyria. Also, the only difference in what's happening at the histological basis is the fact that you have the peel limiting membrane of the brain, and it has holes, and the holes could be induced either by environmental or genetic triggers. And the size of the hole decides how much over-migration or disorganization is happening. So it's a bit of a spectrum. And therefore, to use the term cobblestone polymicrogyria complex, when you have this situation where the cortex looks over-convoluted, the white matter has these bands of signal change, becomes relevant. Of course, at the moment in practice, cobblestone in itself is really associated strongly only with one or two entities, mostly the dystrophic canopathies. But it's a symmetric, thick, bumpy cortex with extensive white matter changes. Then you have the hemimegalencephalies, and I did tell you that when you have one-sided change, there's quite a mixture of malformations you can pick up here. Remember that on post-mortem specimens, this is a lighter brain. It's not the heavier brain. It's quite a spongy brain, which is totally malformed. You can get associated calcification of the white matter, high signal changes as well on the MR sequences. But important, please look at the contralateral side. There will be some surprises there. Might not make a difference to the outcome if they're undergoing a functional hemispherotomy anyways, but the seizures may recur in the contralateral hemisphere. Schizencephaly traditionally was thought as a cleft in the brain, as an acquired insult. It may very well be an acquired insult, but you could also have vascular disruptive genes playing a role in that process. But you're looking at a cleft, structurally speaking, which is lined by dysplastic gray matter, and most likely an early life insult. But when we say early life insult, that could still mean a genetically triggered vascular insult. It doesn't have to be an environmental factor always. Eventually, and this is kind of coming towards the end of this talk, you will see, and we will all see, a lot of children having surgeries, having resections, having palliative techniques done to them as well. So it starts with therapy in terms of medications. It starts with ketogenic diet and other measures put into place. And at the moment, the thinking and the advocation is that there has to be a low threshold to call something refractory, and refractory can be defined even by just failure of one line of medical management, particularly in children when you have found a substrate for it or a surgical target. Then it's important to act early. And we know why now, because we have to make sure those networks don't get activated, the developmental outcomes are better, etc. And of course, the child who is a 1-year-old has more chances of undergoing neuroplasticity compared to other children, and they can heal a little bit of that scar that is created. So these scars that are created, first of all, of course, in the monitoring itself can give you appearances like this, where you have deep electrodes and surface electrodes in the context of SEEG, which is a stereotactic EEG. When you look at these CT scans, they are only done really to check whether the electrodes are not touching each other. The deep electrodes should not touch each other. The deep electrodes should not have a hematoma around them. Those entities can give you a poor read from these electrodes. So that is for the radiologists. When they look at the scans, they wonder what they should report. That's what they need to report. In some centers, you will still see the subdural grid, which has been placed. And the brain appears a bit swollen when they have put a subdural grid for good reasons, because they have opened up and put this grid inside. So a bit of transient brain swelling is expected, and this is what they look like on the topograms. This is a functional hemispherotomy, and when you read a functional hemispherotomy, it will be useful to, we had one paper published some years ago, and we tried to, for the benefit of the radiologists, go through the steps of how a functional hemispherotomy is done. You need to read these scans on multiple planes. You need to know what was the aim of disconnection in terms of how and what steps were incurred. And without going into the details at the moment, we have put a lot of pictures there for you to have a look at. And then when you come back to the image, you will start making sense of why this bit is still there, and why is there a little bit of what looks like commissural tissue attached, and should it be there or not. But the idea is that this is a functional hemispherotomy. We are not going to resect the whole hemisphere and throw it out. And importantly, in the context of functional hemispherotomies, look for vascular structures which may have been compromised in the process. And it's not always a hemispherotomy. You can have a quadrantic dislocate, the TOP, or the temporo-occipitoparietal disconnections, or you can have focal lesionectomies as well. But these are your disconnection surgeries essentially out here. And then the palliative techniques are either a VNS implantation or a callosotomy, and the callosotomy in itself could be a partial or complete callosotomy. This particular patient initially had a partial callosotomy. The surgeons encountered a lot of blood vessels in the choroid plexus area, so they stopped. It's a palliative measure. The idea is not to make them seizure-free. The idea is to reduce the frequency of seizures, and particularly in the context of atonic drops and those scenarios, callosotomy can be quite useful. And patient went on to have a complete callosotomy, or what was thought to be a complete callosotomy. And in these measures, techniques like DTI do have some role to play, where you can pick up residual connections. DTI, I did not say about much. It's useful for surgical workup. In itself, it has not really helped us detect a lesion that we did not see anywhere else. DTI, standing for diffusion tract imaging in tractography, is to complete the tensor imaging that it gives you, is to help the surgeons map out areas and also to kind of avoid important areas and try to keep the surgery as minimally invasive as possible. So some pictures that might look like this in terms of those children who have been treated either for diagnostic or palliative measures out from our paper. Final reflection for the radiologists, for the clinicians. We use the term seizure-related change quite a lot in our reports. And in fact, a piece of work that needs doing is, what exactly is a seizure-related change? You can pick that up as swelling. You can pick that up as some kind of density or intensity change. You can pick that up as restricted diffusion as well. But what is the future of that seizure-related change is important. So here we had a CT scan. This wasn't called seizure-related change. What was called seizure-related change was the MRI. So we had all the signal change. The CT showed this hyperdensity out there, which could be partly calcified. It could be a cavernoma. It could be so many different things. Lots of things can look like that on CT. You can see that I haven't shown you many CT scans. I don't think CT has a role in epilepsy per se. It might have a role in new onset seizures with new neurology, which is lateralizing and focal in the acute setting. But the moment you're starting to think epilepsy, you should start looking at MRI and optimizing your sequences. So axial T2 flare diffusion, a little bit of heterogeneity to the diffusion as well. And contrast was also given. Now that's interesting. Contrast improves your specificity, but does not improve your sensitivity. And contrast can actually make it confusing for you, because you might end up picking up enhancement in areas which are actively triggering out and firing out. So this was called seizure-related change. And the patient then was sent back to their Northern London District General Hospital. They had a follow-up scan. And the follow-up scan was read by the radiologist as no change. In retrospect, you will agree that there is a change, and that's a change on the DWI, which is quite a big change compared to that little spot. But this was read as no change and was left in the system as ongoing seizure-related changes. Eventually, the child comes back with an enhancing mass, which was then called a glioblastoma multiforme. We would call it a high-grade glioma, IDH wild type at this point in time. This was before the 2016 and 2021 iterations of the World Health Organization tumor classification. So what might be a seizure-related change might be real and around the problem, but you might be dealing with another issue which can go unnoticed if you focus too much on just transient changes. And really with that, this is my summary slide. We are looking for focal cortical dysplasias, but don't forget that there could be ancillary findings like tumors, hippocampal sclerosis, previous infarcts in the brain. A tiered multidisciplinary approach is what we have tried to show you through Ria's story today, who is still very happy and growing well without much developmental issues. And then the various strategies, both very basic bedside, I would call that PACS side strategies, as well as more sophisticated things on the horizon that have added value to the practice, and eventually the meticulous review and re-review of images that makes a difference. My acknowledgements here, particularly Spin Academics and Pradeep Krishnan, who have highly got inspired from his presentations on pediatric epilepsy. And then my neurologist, Suresh Pujar, who teaches me a little bit about EEG, Ashwin and Zubair, both eminent neurosurgeons who have helped me understand SEEG a little more and what exactly happens in the theaters behind closed doors. I thank you for your attention.
Thank you so much, Dr. Mankad. So when the presentation is very crisp and clear, you may not find too many questions in the chat box. So that is excellent. But I think we have one question, and some of us have several questions. So, Gianluca, do you want to read that question out loud for Dr. Mankad? You want to unmute?
Yes, there is a question in the chat from Tanya. Brain plasticity in children. How should be the child to recover all function, motor, sensory, language after surgery in a loquine cortex? Any difference in recovery of motor language depending on age?
Not that I'm aware of, to be honest. We will all have to dive deep into the literature, but I can tell you that the neuroplasticity concept is the best under the age of 1 year of age. I think we still have the benefit of that in the younger children, but it's rapidly lost after that. So if I were to give the an analogy of the brain maturation side of things, by the time your T2 weighted sequences have shown maturation of myelin, which is around 24 to 30 months, after that, you start losing your plasticity as well quite tremendously. So earlier, the better. And that is why in the context of children where you have a problem and a lesion that has been shown, even in tumor world, we would advocate early resection, get rid of the problem and let the brain see what it does with its rewiring.
We agree that catch them young. So if you really want to do the epilepsy surgery, it is better to do them early, given the appropriate context. But I really like the idea of myelin maturation. That is the first time I am hearing such an explanation, but that really makes sense. I have a few questions, Dr. Mankad. The first one is, suppose the MRI brain is read as normal, but based on the subsequent neurophysiology, the radiologist goes back and reports something. How often there is an overcalling based on the surgical pathology specimen?
Quite often, actually. On the initial radiology report, we have both things. And I can tell you now from experience that in the first 5 years as a radiologist, you are an overcaller. Then you become an undercaller. And after 10 years, you become an overcaller again. So it's kind of a bit of a maturity wave which goes in circles. And it is physiological to an extent because you don't want to miss things when you've got started. So you start looking at every area of blurring, and you realize very soon that you're going to get a bit of that blurring in the occipital area. That temporal area will be a little bit blurred anyways. Then you have your thresholds change. And then you realize after a while in time, when you have had many more discussions with your clinicians and you start understanding the semiology a little more, you know where to look at. So it goes through waves. I wouldn't be able to give a percentage, but I think it depends a lot on the radiologist as well. And also on the quality of the scan, because if you do a poor quality flare, for instance, you will end up calling blurring everywhere.
Okay. I think we have a few more questions. Gianluca?
Yes. Tanya, many centers still have 1.5 Tesla MRI. Are they missing many lesions?
I'm just going to say that if you have a well-optimized 1.5T, you're doing okay. You don't have to shed tears about not having a 3 Tesla. We cannot change that resource set in many, many countries. So we can't say that this is the Bible and that's all you need to have. You probably are potentially missing lesions because we know, and it's been published quite extensively, that the yield of 3 Tesla imaging is better than 1.5 Tesla. If you want to make a business case to your managers and you think they have the money, you can use a lot of literature to support that. But I say these words with a lot of hesitation and caution because I know what the worldwide situation is in terms of scanners and who's using what. Even in the city of London, in the private sector, if a child needs a GA scan, there is one scanner, which is a 3 Tesla scanner. So we're still relying on 1.5 technology with all the epilepsy syndromes going through in the private practice. And I'm on record right now, and I think that practice should change, at least for the private sector.
We have another question from Dr. Kevin Jones, who is my colleague. Are there any MRI signs to suggest a filaminopathy or a oligodendrogliosis, or are these pathological diagnoses alone?
The filaminopathy is actually easy for us because we then look for lots of nodules of gray matter heterotopia lining the ventricles. And our typical phenomenopathy patient, the FLNA mutation, would have heterotopias lining the ventricles. The hippocampi will be malrotated. And when we tell you that, and when you look at the patient, it kind of fits in because they have some other features as well, clinically speaking. The oligodendrogliosis is interesting.